Alright, go ahead and get focused if you so choose or need to. This is chapter 3. And a lot of this stuff is bread and butter, meaning some of it is almost boring and simple, although obviously because it's bread and butter, it's also very important because you will see a lot of it. And it's even if you never look at dermapath ever again after you leave dermatology, because some people just can't wait for that, that's fine, but it's always good to know what it looks like in the microscope for those who do, and particularly in things like how deep to get on biopsies and that sort of stuff. So this first one is a run-of-the-mill actinic keratosis. Now, it's a little bit hypertrophic, and so technically it's a hypertrophic AK. And some of the important things to think about when you first see this, whether it's on a test or in real world, is you say, oh, okay, well, it was certainly thickened, but why is it just maybe a seborrheic keratosis? Is it something else that's going on? And there's some clues even from scan. We always like to say, oh, you can diagnose everything from scan. Certainly that's not always true. You got to get down in deeper. But from scan, you can see a couple things that help distinguish it from just a run-of-the-mill seborrheic keratosis. It doesn't quite have that line sign that we talked about for seborrheic keratosis. It's fairly well defined and fairly small. But those seborrheic keratoses, they were just kind of this perfectly little, well circumscribed kind of blunted pushing border into the superficial dermis. And it was literally like you could draw a line at the base of it. Whereas here, you kind of have that, but there's some hyperplasia, more irregular acanthosis that kind of goes along. So that's one clue that maybe this is something a little bit different. And then you do not see any true pseudo horn cysts like you would see with the seborrheic keratosis that are intraepidermal. This little guy down here kind of almost looks like it, but really you don't have those horn cysts. And then the other thing is the horn. And so this is classic for a malignant horn, and it has that flag sign, which that's where you see this kind of thickened, what appears from here to be orthokeratosis, although it's actually para, and that is very important. And so it's this kind of thickened parakeratosis, but then you get despairing over adnexa. Now you can start to lose that as something turns into really horrible squamous cell carcinoma, and the atypical cells are diving down adnexa. But for a lot of the lifespan of the lesion, it's the columns above the adnexa are spared because it just doesn't really go down the adnexa. And so that's what this stratum corneum is normal, because it's above maybe an eccrine gland or hair follicle or something. And it's all this intra-adnexal epidermis that's affected. And so this flag sign of kind of this reddish parakeratosis and this bluish columns, which there's actually an eponym for it I just learned the other day. It's called the Freudenthal funnel. You don't have to know that at all. So that kind of flag sign is a clue to it being something malignant, whether it's an AK or squamous cell carcinoma or bones or something of that nature. And so just from this scan, you're kind of like, man, it's probably just an AK. But you want to do a couple things to confirm that. You get a little closer in, and you can kind of start to make out the actual true parakeratosis. And with parakeratosis, generally you're going to kind of lose that granular layer. Now, some areas it's spared, although typically it's spared in these adnexal areas. But generally you're kind of losing that granular layer. And then you start to notice that the basal layer of the epidermis is a little bit atypical. And one good way to know that is you compare it to the surrounding epidermis. And so over here you see a nice granular layer, normal ortho, vascular stratum corneum, and then you see a pretty normal appearing epidermis, but then over here that basal layer becomes a little bit more prominent, and you get crowding, atypia, pleomorphism, high nuclear to cytoplasm ratio, meaning there's a whole lot more of that really thick, dark, bluish chromatin and really no cytoplasm. And you can see these cells are all, pleomorphism means they're all different sizes, and some are large and atypical appearing. But it's really isolated to the base. It's really just at the bottom. It kind of, the cells, as they come up, they still sort of flatten out and mature. And so because it is not full thickness atypia, it's just a run-of-the-mill actinic keratosis. And so just getting down a little bit deeper, you can really make out that parakeratosis now. And you can see there's retained nuclei in there, and loss of the granular layer. And then these cells, particularly down at the basal layer, are just kind of more atypical appearing, a little bit more pleomorphic. You might even see mitoses and whatnot. If we search, we could probably find some. But they're really, if there are any, they're kind of isolated to the base of this lesion, and things, as it comes up, for the most part, mature and kind of flatten out. And so that is a run-of-the-mill actinic keratosis. And a little hypertrophic, technically. Okay. So this next one, kind of switching gears a little bit, is a desmoplastic basal cell carcinoma. And basically it's a morphiiform basal cell carcinoma. And, you know, from scan, this is probably an excision, you know, big, huge piece of tissue. And maybe initially it doesn't look a whole lot atypically. It's hard to see really what's going on in this. I mean, the top layer, the epidermis, looks pretty normal. Maybe there's some solar elastosis in here, and you see some hair follicles and whatnot. But even from scan, you can kind of start to see, you know, maybe there are some little islands in here of these little strands of something, and that's not really ever normal. So we get down a little bit deeper, and another thing you can kind of see from scan are these nodular lymphoid aggregates, which those also are not really ever a good thing. You know, they certainly can be just any sort of run-of-the-mill inflammation, but anytime you start thinking, is this cancer, and you see nodular lymphoid aggregates, that usually gives you yet another point of confirmation or evidence of saying, yeah, this might be something bad. Now, this at large is what we call the Paisley-Tide differential, and the reason for that is because all these little polka-dotted looking Paisley tie, you know, little strands and islands look like little Paisley ties. And it's a differential because there's 4 big things that can look almost identical, and there's only subtle clues that can help point out the differences. And there's a couple different ways you can remember it. As with most things in dermatology, there's little sayings and acronyms, and that's how we get by. With the Paisley-Tide differential, someone a long time ago came up with "my suit defines me." I actually prefer to modify it and say "my suit defines my body." And so the way that helps you remember it is Paisley tie goes with, you know, a suit. I don't know who wears a Paisley tie these days, but, you know, still might wear it. And so you wear that with a suit, and so then "my suit defines me," that goes with, the M goes with MAC, or microcystic adnexal carcinoma. The suit goes with syringomas. D goes with desmoplastic trichoepithelioma. And then "my body" goes with morphiiform basal cell, which is basically what this is. And so all 4 of those things can look very, very similar. And later, next chapter, when we start going through adnexal neoplasms, we'll kind of get to more of the subtle clues to differentiate them. Because with this morphiiform basal cell, you can't, a lot of times you don't really see the tumor stromal clefting like you would with a run-of-the-mill basal cell. You may not see that classic fibromyxoid stroma. These nodular lymphoid aggregates, though, are very suggestive of cancer, and so can help you distinguish from a desmoplastic trichoep or syringoma. They're a little bit more common in the MACs, and so but they certainly can be in a morphiiform basal cell as well. So the important part of this slide is just to know that these little tumor things are not normal. They may not look that scary. You don't see tons of weird cells or mitoses or things of that nature, but these little islands, even though there's no tumor stromal clefting, are atypical and not normal, and it's technically a basal cell. And they're not as blue as you normally would think of as a basal cell, but that's what this is. And you can stain it. I mean, there's different things you would do to kind of help confirm that. But that's a morphiiform or desmoplastic basal cell. And in case people aren't sure, I mean, I think it took me probably a year to figure out what desmoplasia means. Desmoplasia really just means sclerotic collagen formation, and that sort of sclerosis that can occur as a result of some sort of tumor. And it's not always a bad tumor, because we have desmoplastic trichoepitheliomas and things, desmoplastic tricholamomas, but that's kind of what that desmoplasia means, is that kind of sclerosis. So this, from scan, kind of looks a little unique. There's what appears to be horn cysts in here almost. And so you think, oh, maybe this is a seborrheic keratosis, but it doesn't look classic for a seborrheic keratosis. And this is an Infundibular cystic basal cell carcinoma. It's kind of a unique form, and you can sort of make out these nice peripheral palisade and blue islands that you can say, oh yeah, that I can see how that's a basal cell. But what's unique is that you've got these little pink islands in here, almost look like keratin formation, and you can get some horn cyst formation that is reminiscent of a seborrheic keratosis. And so it's sort of a unique type of basal cell, and sometimes the tumor stromal clefting is not as pronounced. Of course, that goes with all basal cells. You may not see it, but if you do see it, that certainly is helpful. You may see some atypical cells and mitosis in here because it is, a form of skin cancer. It is important to know, because in dermatology you're supposed to know everything, that there is something called a basaloid follicular hamartoma. And the only reason to know that is because it looks exactly like this, essentially. It is more of a congenital lesion. And so, for example, if you biopsied this, or if you biopsied something on the face or something that maybe looked a little Blaschkoid, but you biopsied it in like a 9-year-old, and then the path report came back and said, Infundibular cystic basal cell. Well, it could be, but it's probably a basaloid follicular hamartoma, which is more of just a little congenital lesion, not something super concerning per se. And so you kind of treat it a little bit differently. But they look very, very similar. So it's more that clinical history that can help you point that out. But the reason why this one's unique is it has sort of that overlap with a seborrheic keratosis. It also has kind of pink, not really strands, but sort of pink strands and blue buds, not quite like a fibroepithelioma of pincus, which we'll get to, or other things that can do that. But it just has a somewhat more unique characteristic. But here, out of the periphery, you can really see that palisading. And hopefully you'd be able to find maybe some tumor stromal clefting, but that's an infundibular cystic basal cell. Moving on to number 4. So this one is Bowen's, or squamous cell carcinoma in situ. And at scan, you say, all right, well, those cells look jacked up, and so you start to get a feel for it. The more slides you look at it, you're like, that just doesn't look right. And so that's probably cancer, and man, it looks full thickness, so that's probably a Bowen's cell, or a Bowen's disease. But there's just a few quick things to point out. It maybe almost has a hint of some clear cell change in some areas. And the reason why that's important is because you look over here, that almost is reminiscent of a clear cell acanthoma. And so you might be on a test or something looking at this like, oh, I'm sure it's just a clear cell acanthoma. There's some neutrophils up here, which I know you're supposed to get with clear cell acanthoma. Almost looks psoriasiform like the clear cell acanthoma. But there's newts up here because it's eroded. I mean, that's just superficial erosion on the top of cancer, like we often get. And it's probably secondarily incontigenized, so you got some neutrophils up there. And you can get clear cell change in a lot of things, to include clear cell bones. And this isn't like true, full-on clear cell change, but you can see that it does have sort of that almost well-demarcated appearance. And that's also not surprising because you can get clonal bones and clonal things that have clear cell change and can be very well circumscribed. But again, getting back to just the lesion in general, these cells look jacked up, and they're very basophilic for normal epidermis. And once again, you can always try to find the periphery, which you may not get on a superficial or thin shave, so a reason to get a good deep shave on some things you're worried about. But over here is all normal epidermis, completely normal, nice maturation, whereas then you compare it to these cells, and there's this really dark basophilic, high nuclear to chromatin or cytoplasm ratio. And then when you get down a little bit deeper, which is always the tendency for dermatologists, like, oh, I got to get in deep to look at it. But as you get in deeper, you can see all these cells are pleomorphic. They look a little bit different from each other. And one thing that is important, though, is this is still bones, because even though it's full thickness atypia, you still have a pretty nice, well-defined basement membrane. Everything's really, kind of controlled and contained within this basement membrane. And so it does not appear that it has started to invade. And if you get in much deeper, you can start to see it's kind of like those magic eye pictures. Once you find a mitosis, you'll start to see them all over the place. And so, up here, you can see, mitosis right there. And there's probably plenty more in here once you kind of start to see them. All these are little mitotic figures. So lots of mitoses, that's not normal. And that's a bone cell. There's some repeats in here, so as we get more on to repeats, we'll go a little faster. Okay, number 5. So this one is a keratoacanthoma. And so, there are certainly, both in derm literature and in the path side, why do we still talk about keratoacanthomas? And I'm not sure what they teach you guys here, but there's certainly controversy. There's people that think it's its own entity. It's just completely separate from squamous cell carcinoma. It's similar, but it's separate. Other people that say, look, it's really just squamous cell, but it's well differentiated. I'm kind of more right in the middle, and that's where I think a lot of people are, because they say that it is important to know when something has that classic keratoacanthoma appearance under the microscope, because why did that happen? So if you have that classic appearance under the microscope, then that can sometimes give you a little bit more clinical options, because we know that some keratoacanthomas, they differentiate themselves, they keratinize themselves to death, basically, and so they regress in maybe a few months, maybe whatever, but eventually they kind of go away on their own. And I had a patient who was this relatively younger 30-year-old girl, never had skin cancer before, and had the classic 3 weeks probably took for this classic appearing Ka to appear on her nose. And so, I biopsied it, came back classic Ka. Do I send her to Mohs? You say, oh yeah, of course, it's squamous cell, I got to send her to Mohs. But I didn't. I just basically gave her Efidex, never came back again. So you use all those clinical things and the path and all that stuff together to then save that patient a huge paramedian nasal flap or some weird cancer. And that's not always going to happen, but it is nice to know when you get classic keratoacanthoma. Now, in terms of derm path, it's going to have more of this central keratinaceous plug. Here it's not as well defined per se in that cut. A little bit more here. You can just see this really thick kind of central keratinaceous plug. And then the epithelium usually has this very glassy appearance, and that's kind of classic for keratoacanthoma. Sometimes verrucas carcinomas can have a little bit of that too, and can be a little bit confusing. But it's just this very well-defined crateriform lesion, more blunted pushing borders versus spiky little invasive islands. Now there is some areas that are a little bit concerning, and in the derm path world, would we call this a Ka or would we call this a crateriform squamous cell carcinoma? Who knows? That's something you sort of decide with your gestalt. But you kind of get a little lipping too, which is just where you get sort of some infolding of the upper epidermis. It's actually probably easier to see here, but you kind of this little lip that forms over that keratinaceous plug. And generally speaking, keratoacanthomas don't look super worrisome when you get down in deeper. So let me get a little bit deeper. And so with your classic keratoacanthoma, you get these little keratin pearls, just like you can get with squamous cell carcinoma. So little keratin pearl formation. Now there are some pretty funky atypical mitoses here. So maybe that would push someone to say, well, it's got Ka features, but I'm still going to call it a squame, and what's going on down here is there may be some invasive component. It's not as blunted as I would like it to be. But there are some other features you can look for to maybe help push you into the Ka world. If you see tons of eosinophils in here, that's usually a bit more indicative of a Ka and less of a squamous cell. And there are some eosinophils in here. Most of what you see are neutrophils, but this little bilobe guy here is definitely a eosinophil. You get little microabscess formation sometimes in these tumor islands, and then you can get, that's probably what this is here, this is probably elastophagocytosis, this probably is as well. And when you see this little sort of eating of the elastin fibers, that kind of goes a little bit more with Ka as well. So there's just different features that may not really matter a whole lot to someone who's doing derm, not doing derm path anymore. But it's important to know those. It's important to know who's reading your slides and how much stock you put in the whole Ka versus squamous cell carcinoma thing. So this one is more of a invasive squamous cell carcinoma, and kind of has almost that crateriform cup-like architecture, but it's not nearly as well defined as blunted. And it's also got some acantholysis, which Elston in his book says Kas never have acantholysis. Anytime there's a word that's never, you should probably underline it. Just like always in neutrophils for clear cell acanthoma in the stratum corneum. But this just has these weird kind of projections, and then what you really see here are these little spiky islands that are kind of coming off these very atypical islands That's invasive squamous cell carcinoma. And again, that acantholysis. Like here, for example, when you see these little islands kind of spitting off and little spiky things sort of coming off, that has become invasive. It's no longer Bowen's or something of that nature. And then in terms of acantholysis, that's what all this is. So these cells are just becoming less differentiated, so they're all just sort of falling apart. And then within here, you do see tons of mitotic figures. You probably see a lot of them deeper in as well. And that would help you distinguish, if you just see the acantholytic disc keratosis, which there's some of that in here, you might say, oh, is this warty disc keratoma or something of that nature. But then when you see tons of mitoses, for example, weird looking jacked up mitosis there, mitosis. You can see all these mitoses, that's not normal, and that's not just some warty disc keratoma or something of that nature. So this is more of a true invasive squamous cell carcinoma. That was number 6. Okay, so number 7. This one is also just a squamous cell carcinoma, and the kind of teaching points for this one is when you look at just this upper part of the epidermis, this almost looks normal. But then somewhere around here, there probably was this AK that turned into bones, that turned into squamous cell carcinoma, and you get all these down here, there's obviously something going on. And these islands just look atypical. They're all jacked up. Some of them are kind of falling apart. And the lymphoid infiltrate here can make things a little bit difficult. It kind of just makes everything all smudgy and hard to really see spiky islands. And sometimes it can be hard to differentiate, is this turned into actually invasive squamous cell carcinoma, or is it maybe still Bowen's, or is it something else that's just being occluded by the infiltrate. But anytime you see these sort of spiky projections, especially when they're islands all by themselves, that's not normal. There is a little bit of acantholysis with this as well, but that's invasive squamous cell carcinoma. That's not normal. All this is just sort of invading the dermis and falling apart. And then certainly, if you go on a mitosis hunt, you'll find some of those as well. So you can always find these mitoses to help make yourself feel better that it's something bad. So another squamous cell carcinoma for 7. Okay, now this one is a fibroepithelioma of Pincus. And this cut here is not necessarily classic for it. You could still theoretically get to the diagnosis from this alone. But this one looks weird. You got like these islands kind of down here, and just kind of looks odd. But that's just because of how it's cut. When you get over here, you kind of see, oh, there's that classic fibroepithelioma of Pincus appearance. Now, what I will say is that this cut really shows you that fibromyxoid stroma. Sometimes that can be hard to see as you're kind of learning basal cells, because this is essentially a variant of basal cell. But that's what all this is. You can see how all this part of the dermis looks very different from very normal dermis down here. And all that's that kind of fibromyxoid stroma. And the stroma is the tumor. And so, stroma to the margin is a positive margin. And so whether it's Mohs or getting an excision cut or something, if you got stroma to the margin, it's still positive. With fibroepithelioma of Pincus, it's this classic blue buds, so pink strands and bluer buds, and it's this fine, thin, interlacing, kind of reticulated pattern. You can actually get little eccrine duct formation in the center of these islands. And this can look very similar to syringofibromatosis of fibroadenoma of Mascaro, or syringofibromatosis, which that's kind of more in the Untitled Chapter, which we'll get to later. But even though they can look pretty similar, that fibromyxoid stroma can help to distinguish it. But seeing these peripheral palisading, almost more classic basal cell looking blue buds with these pink strands, that's a fibroepithelioma of Pincus. Generally considered a little less concerning than your typical run-of-the-mill basal cell, although we treat the same. Classically located clinically on the lower back. It's the most common location, although you can get it anywhere. Okay, So this one is a good example of, you know, for derm path where the derm world and the path world kind of combine. To a lot of the path residents, they're like, oh, this is obviously breast. To a derm resident, you'd be like, what is all this stuff? Is this like metastatic cancer or something? I mean, you'd be freaking out. But these are just kind of normal glands as part of normal nipple or breast tissue. And I'm zoomed out as far as I can, but it's a pretty big piece of tissue. And you can kind of see there's almost like this little mammillated nipple-looking top piece of skin here. And that's because this is a nipple. And you guys will kind of need to learn that because that can be on the boards, whether it's erosive adenomatosis of the nipple, which is kind of like SPAP on the nipple, or something like this, which is Paget's disease on the nipple. You know, this is something you could still get on a boards or need to know. And so you get this mammillated structure here that's reminiscent of a nipple, and then you get these sort of longitudinal you know, columns of glandular tissue. And it kind of goes deep, and you'll probably see you know, smooth muscle bundles and lots of nerves and things because of the location. But anyway, so that's a nipple. But what's going on is all up here, and you can see from scan it just doesn't look right. There's something going on. You say maybe there's Bowens in there, maybe there's something else in there. But then when you get in deeper, you can see that those cells just look a little weird, and they're pretty well defined actually. So you can see they're a lot paler than the normal epidermis. Have this sort of amphiphilic cytoplasm. They're sort of pushing away the normal skin around it, and then you can start to see somewhere in here kind of pagetoid spread. It's a little bit hard to see because everything else is pale staining, but all the tumor cells are in here, and they're kind of percolating up. You can kind of see they're sort of percolating up through the epidermis, and you're seeing that pagetoid spread. So that brings up a differential, right? So the pagetoid differential. And same thing with the Paisley-Tie thing. You guys maybe learn different ways to remember it, but one of the ways I was taught was BMs in the PM. If you guys have heard that one. So basically bowel movements in the PM. But that stands for all the things you can think of for the pagetoid differential. B stands for Bowens. M stands for melanoma. The S, so BMs, the S stands for sebaceous carcinoma. N stands for intraepidermal porocarcinoma. And then P stands for Paget's. And then actually that last M, so BM's in the PM, that last M you could technically put Merkel cell carcinoma as well. Sometimes with Merkel cell carcinoma you can see pagetoid spread. So BM's in the PM is a great way to remember all the different pagetoid spread differential. And you know, there's different ways to stain it, of course. With classic Paget's disease, it should be PAS positive, but so would Bowen's disease. They're both PAS positive, but that's where that whole diastase-resistant, diastase-labile thing comes about, if you remember that. Diastase dissolves glycogen, which is what's happening with clear cell change or glycogen accumulation in Bowen's. And so if you use the diastase with Bowen's, the PAS will no longer be positive, and so that's diastase labile, whereas Paget's is sialomucin, and so that does not dissolve with diastase because it's not glycogen. And so it is PAS positive, diastase resistant. You can also use CEA. CEA is positive in Paget's and negative in Bowen's or squamous cell. So this brings up a differential. It's pagetoid spread. There's another case later on that's you can see the cells a little bit better, but you'd have to stain this, and of course the location helps figure things out. But so some people also say that if the little pagetoid pagetoid nests go into the stratum corneum, that's a little bit more likely in melanoma and less likely in Paget's and Bowen's. I wouldn't necessarily hang your hat on that, but that's another clue. So this is another infundibular cystic basal cell, and once again you can see has that sort of overlap between basal cell, maybe a hint of fibroepithelium of pincus thrown in, but then seborrheic keratosis with those horn cysts. So it's kind of a little mixture of all those, but it's officially a basal cell. And again, as with all basal cells, but particularly these variants, you may not see that classic tumor stromal clefting that we see with nodular and superficial multifocal, and that pinkness to it, a little bit of pinkness, sometimes makes you think, well, is this a squamous cell or is this something else? It's not necessarily as brightly blue, and so you really want to look out to more the periphery, because the periphery is where you might see a little bit more of that classic peripheral palisading. It's a little subtle here, but if you see that peripheral palisade, that can be helpful. And then that fibromyxoid stroma, which you don't see as much here. It's harder to see. It's in between all these islands, but you don't see it as well defined. Maybe here you can see how the stroma kind of goes to here, and then you get normal dermis and collagen. But uniquely with this type is the pseudo horn cyst formation. That's really annoying. Okay, your job is to move this every once in a while.
Sure.
All right, so infundibular cystic basal cell, that's number 10. Okay. Now you guys have seen this a lot, and this is easy. I mean, this is just a basal cell carcinoma. This is kind of more classic. And this one is probably like, micronodular is what I would call it. Some of those, a lot of times with basal cells you get a little bit of overlap. It's a little bit of all or multiple variants. But this is a great example of, from scan, these very basophilic blue islands with peripheral palisade that you can even see from here, how that really lines up. Palisade means fence, so it's kind of how it lines up on that periphery. But then in between these islands, you get that slightly bluish or myxoid, that fibromyxoid stroma that's all throughout these tumor islands. And that's kind of what is very helpful, because you don't see that fibromyxoid stroma in something like a run-of-the-mill trichoepithelioma, which we'll get to with the adnexal stuff, and that can be a good distinguisher. So this is probably more micronodular. You can get calcium. That's probably just a tumor island falling out, but there's actually some calcium there. You can get calcium formation in basal cells. And why is that important? Because calcium is a little bit more common, perhaps in desmoplastic trichoepitheliomas, but you can get it in basal cells too. So it's not a perfect differentiator. You can also get it in microcystic adnexal carcinomas. Okay. This one is number 12. This is another Paget's disease. And this one's more extramammary Paget's. The last one is on the nipple, so technically I guess it'd be true Paget's. But so this one, from scan, you just look at the dermis, and it doesn't look that weird. There's not really anything going on. But even from here, you can kind of see epidermis. There's something going on there. There's little clear-ish looking cells. And then you get in a little closer, and you say, oh yeah, there's definitely, that's where the money is. So on a test, that's where you zone in, because you only have so much time. And it brings a differential. So could you say this is absolutely Paget's and not Bowen's? Probably not. There's maybe some subtle clues. With Bowen's, it usually crushes the basal layer. It kind of almost looks like it does here as well. But so there are some subtle clues, but this is a differential. Could it be melanoma? Probably not. They don't look like classic for melanocytes. You'd hopefully see some pigment, and you don't really see that here. So again, there's subtle clues, but this is a Pagetoid differential. And there are other things, by the way, that can look like this that are normal. There's something called clear cell papulosis. This is more just for you to be aware of. Clear cell papulosis is a kind of more benign tumor formation. It probably is better termed Toker cell papulosis because it comes from the Toker cells, which is also what Paget's comes from. And it can look very similar because it's sort of the same thing but more benign. And then there's also something called Pagetoid disc keratosis, which is more of a processing artifact. And that's where you get what looks like Pagetoid spread, but it's kind of more isolated to the top part of the epidermis. Those are just things for you to hear once and be like, oh, there's such a thing that's called that, and that's pretty much it. But you wouldn't really get that on a test, I doubt it. So number 13. So this is a run-of-the-mill superficial multifocal basal cell. It's a little bit pale staining slide, so it's not as basophilic. It's not that nice blue like you like to see, and it's harder to make out that fibromyxoid stroma without the more of that bluish appearance. But this one is just really good for showing that classic tumor stromal clefting. And that phrase tumor stromal clefting is important because that helps to distinguish from stromal clefting, which you can see with other things, more benign adnexal things. So this is tumor stromal clefting of run-of-the-mill superficial basal cell. We're moving faster now because there's a lot of repeats. This one is another fibroepithelioma of Pincus. Really good example of those pink strands and blue buds, those fine, thin, interlacing strands, and just those nice kind of peripheral palisade of those blue buds. So, pretty classic fibroepithelioma of Pincus. Moving on. 15. So this is for comparison. This is actually warty disc keratoma. This is, again, number 15. And if you remember from last chapter, this is kind of this cup-like little downward growth, more endophytic. And there's acantholysis in here with what looks like little pseudo villi formation. And some in here for comparison because, is it acantholytic squame? And you get more true acantholytic disc keratosis. There's probably some corons. You can imagine some grains in here maybe. And you get that villi formation, and everything else looks normal. So you have retention of the granular layer. You've got really well-defined structures here. And even though the cells maybe look a little bit different than normal, they're all pretty much the same, so you don't get really that pleomorphism where all the nuclei are kind of different size. For the most part, they're all kind of the same. You don't see tons of mitotic figures. It looks pretty bland otherwise. And so all those things together, plus with the clinical and with sort of benign features, it's just a warty disc keratoma, but in there for comparison. Okay. And this one is another. Let me just double check my little cheat list here. Okay. So this one is another acantholytic squamous cell carcinoma for immediate comparison with that warty disc keratoma. So here it can look very similar. It's not a kind of one little cup-shaped structure though. This is sort of more multiple acantholytic islands. And you get more of a malignant horn on top, which you really typically don't get with warty disc keratoma. And what really sells it is when you go in deeper. I'm not going to do an exhaustive search here, but you'll probably see tons of mitotic figures and stuff, like the one right in the middle there. So, mitoses and things all over the place. And so that kind of, and anything that's proliferating can have mitoses. So warty disc keratoma still would proliferate. Maybe you'd have one. But, when you see tons of them all over the place, and it's just more atypical and maybe rapidly growing and not as well defined, all those things kind of speak more to a true acantholytic squamous cell. And you're not seeing a lot of that acantholytic disc keratosis with the corons and grains. It's more just a bunch of falling apart. Almost done. This is a regressing keratoacanthoma, and it has that really large keratinaceous plug here. This is that lipping I was referring to, where you kind of get this little lip over top of it, and it's a lot thinner. The acanthosis is not as pronounced, a little thicker here, but that very blunt, pushing border. This one is regressing just because it's so thin and atrophic. Lots of ciliary elastosis in the dermis to always, help you. Sometimes you need to see all that ciliary elastosis and consider it fertile soil, so to speak, and that sometimes says, oh, this might be something cancerous. But just a regressing keratoacanthoma, if you get down in deep at this, you don't really see a whole lot of, unlikely to see a whole lot of mitoses and things. You certainly still can get a little bit of elastic fibers there that it is consuming. See, like here, for example, it's a really good example of elastophagocytosis, which is more common in keratoacanthomas and less common in a true squamous cell carcinoma. And then if you saw the chock full of EOs, all those things would be like, oh, it's probably a KA. But it's more that overall structure and silhouette. Those other things just are more supportive and make you feel better about it, one way or the other. Okay, this is yet another Bowen's. So I'll kind of just quickly go through this from scan. It just looks atypical. These cells are kind of atypical, and it looks to be full thickness. A little bit of para, so not like a thickened hyperkeratotic malignant horn, but you do get this parakeratotic horn over top of it versus like a seborrheic keratosis, which should really be ortho hyperkeratosis. And then cells are kind of pleomorphic. You get mitoses that are in here. You can see that one pretty plainly right there. And it's full thickness, kind of windblown appearance. So, but it's still pretty well contained within this basement membrane. So it's a Bowen's squamous cell carcinoma in situ and not a legit squam. Okay, and I think this was just another, this is just another example of Paget's. And, without staining and stuff, is it Paget's? Is it Pagetoid Bowen's? But you can see those pretty well-defined cells, a little bit paler staining, and they're kind of floating up, percolating up, or windblown up through the dermis. I'll just make sure. Yeah, it just says Paget's disease, so one would presume it's true Paget's, but you'd really need to kind of stain it or use clinical to kind of help with that. All right, two more. So this one is a Verrucas Carcinoma. Sometimes these can be a little bit tricky because from scan, it certainly has sort of a warty appearance to it, but it's sort of an overlap between a wart and a squame. It's got a lot of these thickened acanthotic proliferations, a little bit more than your typical run-of-the-mill wart. But when you get down in deeper, sometimes you have to imagine this, but you can start to see that this is an invagination, but this is technically the stratum corneum, and you can see more round parakeratosis like you'd see with a wart instead of that thin kind of flattened parakeratosis. You maybe get some areas of hypergranulosis, and then you also get some coilocytic change. So these are kind of looks almost like coilocytes or coilocytic change. See that round parakeratosis? So you start thinking, oh, this is a wart. And maybe it's just a really big wart, or maybe it's warty change to a cyst that I'm just not getting the full cut on. But if you searched around here, which is kind of what it'd be prudent to do, especially if clinical history suspected something weird, you would start to see mitotic figures and things. And so you get some mitoses and stuff in here. And so that might push you to say, well, maybe it's more of a Verrucas carcinoma, and that's not. You kind of need all pieces of the puzzle to really help put that together. But Verrucas carcinoma, of course, HPV 16, 18. There's other ones as well. With a Verrucas cyst, I think it's like 60. We used to say 60 because you have to remember all those for boards and stuff. So this is another Bowen's, and that it's cut a little bit funky here. It kind of has almost that pagetoid appearance. And almost, there's some areas that almost like melanocytic islands, except they're all intraepidermal and they're floating up. But that's kind of more of a weird cut. Over here, you've got what appears to be almost some clear cell change. And of course, we know that you can get clear cell Bowen's and clear cell lots of things. And so it almost has a clear cell clonal Bowen's appearance to it because you get sort of these rounded, fairly well defined areas. If you went on a search, you'd find mitoses and whatnot. This one's a little bit more unassuming. There's not really like this thickened malignant horn on top, so a little bit harder to hang your hat on. But that's clear cell Bowen's. And that's it. The last one I put in here is bonus. I like to throw in these bonuses. Bonus round. This is a run-of-the-mill wart. And I throw this in here just so you can, if you want to go back through these, you can compare this to Verrucas carcinoma. So from scan, right, very well-defined, little kind of inward folding, reedy ridges. You can kind of imagine this clinically looking like a wart. These more church spire, papillomatosis, undulating appearance here. Nice orthokeratotic stratum corneum, so you don't see parakeratosis. You don't see the kind of pink and blue malignant horn. And you get, as Elson says, those kind of cookie-cutter holes in the stratum corneum. And then as you get in closer, you start to see the kind of more rounded parakeratosis, hypergranulosis, coilocytic change, relatively benign appearing epidermis. Now certainly when you find maybe a mitosis or two, that's possible because it's proliferating, but generally speaking, overall benign feature. So if you put all these features together, it's a wart. If it's hard to find any of these features, but except for maybe occasional hints of wart here and there, but it really looks like a squame, well, it's probably more of a squame or maybe a Verrucas carcinoma. And that's it. Any questions?
Thank you, sir.